of keeping on time, I'll go ahead and get started. I'm Rita Britzenhoff here at Atrium Health in Charlotte, North Carolina. We are hosting this session of the AAST Experts on the Hot Seat, and the focus of the session is EGS challenging cases. So our fellows will each be presenting a case to our panel of experts, who I will ask them each to introduce themselves now. So we'll go down the line. Nathan, go ahead. Dr. Mowery.
Hello, I'm Nathan Mowery. I'm at Wake Forest Medical Center. I'm the emergency general surgery medical director there, and I've run the fellowship for the past 14 years there as well, the acute care surgery fellowship, and recently taken the position as the division chief at Ohio State, so moving on to there after the first year, but looking forward to participating.
Thank you. Dr. Cripps?
Michael Cripps. I'm the section chief of trauma and acute care surgery at the University of Colorado and the trauma medical director at the University Hospital there.
Thanks for being here. Dr. Foster?
Good afternoon, everybody. I'm Shannon Foster. I live in Reading, Pennsylvania. I'm a little bit unique, I think, to the group because I'm more of a community-based trauma surgeon working at more than one institution here in Pennsylvania. And I act as the lead for the patient education series in EGS cases for the Open. So thanks for having me.
Thanks for being here. Dr. Gelbard?
My name is Rondi Gelbard. I'm a trauma and acute care surgeon at the University of Alabama at Birmingham. I'm also the ICU medical director for our trauma burn ICU, as well as our surgical ICU.
Excellent. If anyone has any questions or comments, please leave them in the chat. We're not going to interrupt the cases to take questions verbally, just to keep them moving. But I'm going to turn the floor over to Dr. Rita, if you want to introduce yourself.
Good afternoon, everyone. I'm Renford Sindis, and I'm one of the surgical critical care fellows here at Atrium Health, Carolinas Medical Center. So I guess we'll get started at this point. And so I'll be presenting the first case, which is about a right upper extremity wound, and I have no financial disclosures. So I am presenting an 80-year-old male who originally presented to the first of two outside hospitals for fatigue and was ultimately diagnosed with AFib with RVR. He had multiple labs drawn, and he developed a wound at his right peripheral IV site within a few hours. He then was transferred to the second outside hospital for surgical management. He was given doxycycline and ceftriaxone at the first hospital, and then transitioned to vancomycin, cefepime, and clindamycin once he arrived at the second hospital. His initial vitals and labs are noted here. Of note, his temperature was 103.1. He had a leukocytosis of 18.6 and a hyponatremia of 125. As stated, he has AFib, for which he was taking Xarelto. He also has sick sinus syndrome, and he had a pacemaker in place. Also, he has allergies to penicillin and sulfa drugs. And on presentation to the second outside hospital, you'll see the progression of what his wound looked like throughout the first 4 days. So what are your concerns, and what would be your next steps?
Who wants to tackle this wound?
That looks terrible. That you know, when you see these sort of wounds at this rapid progression at that sort of speed with boule, and that really starts getting me worried about a necrotizing infection. I like that I see somebody's already outlined the erythema. That's one of the first things I tell people to do, because you can't tell how fast things are spreading unless you have some sort of marker to identify it. I like that. I like that he's already on the clindamycin with the M protein. And I tell you that this guy's probably headed to an excisional debridement in the OR probably pretty quick.
Yeah, jumping on what Dr. Cripps is saying, I don't like the purple. So if we're going by the images that we can see here as it comes across, of course, we don't have the advantage of no hands here, but the idea of simple cellulitis, meaning erythematous changes, as compared to inflammatory changes that are actually causing tissue destruction. The discoloration, so that purple hue or that dark hue, is indicative that cells are potentially dying in that area. So death is more likely in the setting of infection. So the spread plus the coloration is very concerning, coupled with the vital signs and the overall systemic signs of inflammation that you reviewed in your first two slides. I would be very concerned and want to get in there, I think.
Yeah, I also don't like the sodium of 125. That's a, the laboratory risk index for necrotizing infections is not that great. So, but I'll use a white count of sodium as those two numbers out of that, because they're pretty much always available. And a high white count and low sodium is a bad predictor. Or a good predictor of badness, however you want to say that.
Yeah, I would agree with that. I think his platelets looked like they were 110. I think on the is also whatever you saw it, 104,
Yeah.
and that coupled with the sodium, the rapid progression of it, and I'd be starting to feel all around there, see if there was some type of fluctuates, but having a low threshold to head into it and see what was at the base of that wound.
Betcha.
Yeah, I've seen some like septic thrombophlebitis look pretty bad, but I think with the rapid progression, agreed. The hyponatremia, I'd definitely be worried about an NSTI.
Yeah, what I tell my residents all the time is, remember, necrotizing fasciitis is a surgical diagnosis. The only way you really can make it's in the ER, you got to cut down into it and see what's going on. And, sometimes you cut down, you're like, well, that's not it, but now you know.
So the only thing that gives me pause is you're showing me the only thing that gives me pause is you're showing me 4 days of it.
Yeah,
Is it?
I had not noticed that part. Yeah. That's a very good point. That's a high profile maneuver to wait 4 days on that.
Well, with that being said, this is just 4 days, but they actually didn't do their first excision until hospital day 9. So, and when they excised the wound, they only excised the central aspect of the wound, leaving a significant area of erythema alone. He was then transferred to our hospital on the evening of hospital day 12 for continued surgical management. He was admitted to our STICU for septic shock, although he was hemodynamically stable and off pressors for about 48 hours before he arrived. Of note, all the cultures were no growth to date, but we changed his antibiotics to cefepime, linezolid, and metronidazole. Also of note, he had an ejection fraction of 25%, and below you'll see the vitals and labs when he arrived at our hospital. Again, he was febrile to 102.8, a leukocytosis now to 43.7, and a CRP of greater than 30. And we took him to the operating room the next morning. And so this is hospital day 13. And so how would you assess the wound beds at this point?
I think they look pretty good. I mean, I think you've cut off the red stuff and certainly the purple stuff. I mean, there's some superficial necrosis that I almost would expect from an open wound, but I think in general, it looks like it's a pretty healthy wound base.
I'd hit that muscle with the bovie, see if it's twitching, make sure that that's still viable.
That would be my comment as well. I can't see here, but the idea of, is this juicy or dry? So are we desiccating, or are we sloughing, or are we producing a lot of exudate or fibrinous material? It doesn't look like any of that is here in this fresh bed, which is concerning for all of that muscle viability.
Yeah, and I'll take a yank hour and hit that fascia and just push it. And if it freely dissociates, that's more of a necrotizing fasciitis. If it doesn't, it's a necrotizing soft tissue infection, which are different.
But I want to ask our presenter, so the patient was transferred and there must not have been enough systemic concern to take them immediately, in terms of the decision was to delay and take the patient the next day. So I think what are we missing in that? So we were already on hospital day 9 for the first debridement, then to 13. So is there some other factor at play that this patient actually isn't isn't ill or isn't manifesting illness? What's the disconnect? Because if this were something truly nasty, day 13 without debridement, this patient would have overwhelming sepsis most of the time, even in an immune suppressed state. So are we missing something?
And I would agree with your statement that this is a fairly prolonged progression of this patient's hospital course, that he made it to hospital day 13 before it seemed like the wound was completely debrided. And from the notes at the outside hospital, because he wasn't sent to our hospital until the evening of hospital day 12, and then we took him immediately that morning on hospital day 13. But other than slowly responding to antibiotics with just continued progression of the wound, it didn't seem like they felt the urge to debride him until hospital day 9. However, we felt differently once he made it to our hospital and debrided him fairly soon after arriving.
You said his cultures, even from the wound, were negative.
Everything has been negative.
So at this point, were like other diagnoses entertained?
They were, but not to, I guess, steal my thunder. I will get into that part.
Rondi.
Keep my mouth
Yeah,
shut.
this is a reminder for anybody that's listening. Like I would be very anxious on those initial images of waiting till the hospital day 9 to cut in that. Was there any surgical intervention done at all early on, or was this just watching this wound?
The first surgical
worse?
was on hospital day 9.
Wow. That's a risky maneuver, I think. I get that people don't want to cut into folks unnecessarily, and I understand that. But if you have a wound that's that bad, that's progressed that quick with that amount of erythema and purple and boule, you got to go in sooner. Because if this were a true necrotizing fasciitis and you wait that long, people will die from that. So you really do got to get in there and do surgical incisions sooner.
What about imaging? I'm not much of a fan of imaging for the most part in the diagnosis of necrotizing fasciitis, but had they had imaging of that arm at the previous 2 hospitals?
No imaging that we could find, although we eventually got imaging that I'll show in a few slides. So 2 days after we debrided him, he continued to have ongoing fevers and persistent tachycardia, and now an increasing pressure requirement now in norepinephrine and epi. He had progressively worsening erythema and ischemia to the wound edges, and still there are no cultures, nothing grew to date. He was brought into meropenem and micafungin with continuation of the linezolid that he was already in. And as you can see here, he had the progressive erythema at the edges that were previously looking healthy. So what would your next steps be?
Well, I think, again, the question of, are we missing something? So in those debridements, when the tissue continues to delineate, did we check fungal cultures? Did we check kind of all of the atypical things? Because this is already day 15, and now we're expanding additional coverage in the setting of no growth. So I think, again, it is the steps of, what have we missed thus far? What tissues were sent for both, pathological assessment, but did we look for hyphae? Did we look for all the atypical growths? Because some of those could actually just take some time to progress. So the idea of no growth to date might be that we just haven't seen them, and broadening to fungal and other coverage seems the biggest concern if things are still spreading. But back to my earlier comment, the continued assumption is that this is an infectious source, but what are potentially some of the other modifiers or comorbids that this patient might be presenting that could lead to some other atypical cutaneous process? So I just throw that out there.
And just to answer your point on the hyphae, that we did send for that, and there was no hyphae or anything else that we could grossly see from this wound bed.
No reason to think there's any issue with the vascular inflow in this arm?
So we, a good segue into this, that we got a CTA of his right upper extremity. And as you can see here, that there was runoff to the level of his wrist. So while we did have concern for vascular inflow, it seemed like he had good perfusion of his limb.
When y'all did your excisions, was there dirty dishwater fluid, any pus, any purulence, or is
No,
this just,
there was not.
it doesn't look right? Yeah, so that's how, I mean, so now you're sitting at, just about 2 weeks into some sort of a bizarre skin and soft tissue issue that's sterile. There's no dirty dishwater. There's no fluid. You got good inflow. So at that point, then I might be calling the pathologists and saying, like, what did that thing look like? That skin and stuff that I sent you look like? Because something's not right. Because you can't, the fact of the matter, because like you can't get to 2 weeks with a rip roaring, necrotizing infection and still be alive like that. That's just not how that works.
Yeah, I was gonna say, I mean, if we didn't have source control and this was true NSTI, you'd expect him to be,
Dead.
yeah, essentially. I mean, I guess my question is, did he have any other lesions, anything like this, anywhere else on his body? And were other, any other markers of inflammation considered at this point? To see what else this could be. Because I don't know, I mean, if it's already, looked like it had fairly good margins at that prior take back or the last take back, and now it's sort of extending beyond that, but looks more like a purpural rash, like purplish discoloration. I don't know if it would warrant taking him back to the operating room at that point. If he's truly that sick, I might take him back and just make sure I'm not missing something, just to wash it out, further evaluate the muscle and fascia. But I think there's other diagnoses at this point.
And you got to be worried about, a super infection on top of a previously sterile excised field. And yeah, because I'm reading number 3 there on the soft tissue gas and the ulnar aspect, which also you got to take with a grain of salt on somebody that's got half their entire forearm denuded and open skin edges. So that's when I just go to the bedside and start poking around, squeezing and looking to see if there's pus or not.
For the sake of time, I'm going to keep progressing with the case. And it seems like we've answered this. So considering negative cultures and wound progression, are there any other diagnoses on your differential? It sounds like we were talking about more systemic illnesses at this point, considering that he had no cultures. And so our thoughts were when we were assessing him, we were assessing for vasculitis. So we actually sent for P-ANCA, C-ANCA. We're looking into calciphylaxis at this time as well. We had sent the calcium phosphate product, and that was 40. We're also looking into potential malignancy as a cause of this at this time, although we did not consult HEMONC at this point. But by hospital day 16, we started him on stress dose steroids with leukocytosis of 43, and he was on 3 pressors at that time. Now, over the next 3 days, his leukocytosis actually improved to 14 without any cultures growing to date. At this point, the muscles, you can see this was on hospital day 18. It was a bedside dressing change. The arm seemed like it was starting to desiccate at this point. But by hospital day 19, again, the leukocytosis had resolved to 14. And at that point, we stopped the steroids. However, by the next day, his leukocytosis increased to 37 and pressors were restarted. And it increased to 53. He was taken back to the operating room on hospital day 22, where he had got a tracheostomy. And then taking a look at the wound, the compartments were described as dusky, slimy appearing with minimal contraction and bleeding with no signs of infection. So the question would be, how would you manage the arm at this point? Would you continue with debridement or would you pursue an amputation?
It sounds like he's still systemically ill. And with the description of that arm with dusky, slimy muscle, no contraction, no bleeding, I would at this point discuss amputation. With the family, with the patients next to kin, if he can't, consent for himself.
There are no words in your description that make me think that limb is salvageable.
Yeah. That's you gave all the buzzwords for,
So you're either leading us or
that's right. Yeah,
or you're baiting. It's a bait and switch.
Yeah, I'm definitely leading you into that. And so after much discussion, we did perform an amputation of the right upper extremity, a transhumeral amputation. And he was afebrile the day after and off pressors, and his leukocytosis did decrease to 43. However, as a curveball, a similar lesion started to appear on the left upper extremity, so the opposite side of the original disease. And we noted that there was some erythema at his AC fossa, and you can see a peripheral IV just just distal to that. And 2 days after we took that peripheral IV out, he started to have a lesion form at that exact same site with a similar appearance. So we performed a punch biopsy at the bedside, and his leukocytosis continued to uptrend. At this point, as he peaked at a white blood cell count of 76. And then of note, ortho did take a look at his right upper extremity stump. No evidence of any active infection. Also, the muscle bed seemed good, so they washed it out, but they did not close it due to the rising leukocytosis. And just wondering if there are any other thoughts on his high leukocytosis.
Yeah, it's clearly got into the nonsensical numbers of what it means and some kind of myelodysplastic thing. At some point around 40, I start losing interest that it's becoming predictive value that one of 75 is worse than one of 40. But that being said, like I think it starts taking down to some other kind of bizarre pathway, like rather than just a pure infectious driven process.
Yeah, I'm with Nate. 30 to 40, there's something dead, right? Anything, it can be colon, can't be blood cells, but after that, that's some sort of other dyscrasia that's not a surgical thing, usually.
Do we
I would
blame
ag-
steroids? No, I wouldn't blame the steroids.
No, I agree with the group. My two questions though are, why did ortho do this debridement if this was a EGS patient? Just because I can't help but ask that in regards to continuity of tissue assessment. Can't help it. There's a bunch of us on, I think, that might have thought that, but didn't mention it. But in regards to the rising leukocytosis, I think this continues to bespeak that there's some sort of systemic inflammatory process at play that may not be mediated by infection. And additionally, even though we know that skip lesions can not be unusual in certain infectious manifestations, skipping all the way to the antecubital fossa on the other extremity is not what I would think of as this is just a skip lesion of the same infection.
Yeah, I agree 100%. And general surgeons can do amputations of forearms, you just cut it off. And he also got better with steroids with the decreasing white count the last time he was on it. So that's probably what I'd start right now while I call other internally type doctors to come see what's going on with that punch biopsy too.
So I can't comment on the orthopedics amputation, but I do know that they've been helping with the debridement of this wound from the beginning. So I'll leave that at that. But to keep the case moving, we did consult hematology on hospital day 28 after his leukocytosis increased into the 70s. And also of note, he was positive for a Stenotrophomonas in a tracheal aspirate. We stopped all the antibiotics at this point, except for levofloxacin for the Stenotrophomonas pneumonia. And we restarted his stress dose hydrocortisone the day after that. And hematology had completed the workup, finding that he had a monoclonal B-cell lymphocytosis, although it's not a true CLL due to having a low absolute lymphocyte count, as well as having no lymphadenopathy on his physical exam or in any imaging. By hospital day 30, his white blood cell count had downtrended to 35, and the pathology came back on the punch biopsy, which showed a primary neutrophilic dermatosis such as pyoderma gangrenosum, Sweet syndrome, and other conditions associated with a systemic disorder. And honestly, in order to get this result, we had to go down to the pathologist and have a discussion on what we actually saw. They actually thought this punch biopsy came from the right upper extremity rather than from the left. So that was additional clarification that needed to be made. So we continued with high-dose steroids and started him on a prednisone taper starting at 50 milligrams BID. You can see our tapering regimen on the right side of the screen. And by hospital day 37, we got the results back from his right upper extremity, and then he was diagnosed with a necrotizing Sweet syndrome. By hospital day 43, he was transferred to a progressive care unit, and he was on the medicine team as primary and continued to progress towards rehab. Unfortunately, he went back into AFib with RVR and hypotension and developed an MRSA bacteremia. primary source would be pneumonia from MRSA and persistent stenotrophomonas. Unfortunately, he went into septic shock and multi-system organ failure and then transitioned to comfort care afterwards. And since necrotizing sweet syndrome seems to be a fairly rare diagnosis, I just wanted to just touch base on what that is. And so it's an inflammatory non-infected skin reaction, which could be associated with a malignancy, and the various variants with the diagnosis that we had was a necrotizing sweet syndrome. It is often associated with previous sites of trauma, so that would explain why he kept developing lesions at PIV sites, although the pathophysiology is not fully understood. In order to get this diagnosis, it is key that we have to get a biopsy or tissue specimen, and the absence of organisms under microscopy or in culture is key to this. Epidemiologically, there's only been 21 documented cases, with this being the 22nd documented case, and the treatment for this is high-dose steroids tapered over 4 to 6 weeks.
Yeah.
Any final thoughts?
Is there a thought, or is a necrotizing variant behave like that? I always thought of it as like pyoderma, granulosum, and those different dermal-based inflammatory things that they did not like lead to necrosis. That, like this guy that had his whole arm kind of rot off and would have caused the muscles to die. Is there a thought that this was two things going on at the same time, like he developed a secondary NSTI or something that associated with it, or is it just thought this was a classic presentation of necrotizing sweet syndrome that I have not been one of the unfortunate people to see the other 21 people on Earth that had it?
That was our thought. We didn't think that he had a superimposed infection of his arm, considering that there wasn't any outward signs of infection, and we never had any bacteria or any cultures under Am stain or microscopy that we could see. So we thought that this was purely just necrotizing sweet syndrome.
That's
and he
not,
improved once we started him on steroids fairly rapidly. And that's another thing associated with sweet syndrome. It's the rapid progression, rapid improvement once we start steroids.
but that's not that
sweet
unusual. I
syndrome.
thought that there was some percentage of, I mean, I can't quote you the exact number, but there's some percentage of necrotizing fascia. I just think it doesn't ever grow anything. That's true. I mean, it could be multi-organism, it could be staph, or it could be occasionally, I think in single digits, just negative cultures as well.
Do you
I mean,
think do you think this guy could have lived if we could have figured that out sooner? I mean, just to be clear, I never would have figured this out. This guy would have died on my care, and it would have been a total mystery.
Yeah.
I never would have figured it out. So kudos to y'all for getting that far. But looking back on it, you say like, oh, hey, at 2 weeks, steroids really try to get this, really help this guy out quite a bit. At that point, instead of going, further along, could you have prevented the pneumonia and all this other stuff along the way, the amputations and whatnot? Is there any, I don't know. This is the first time I've ever heard of sweet syndrome.
Same
So-
for us.
Yeah,
It was the
class.
first
I
for us
mean,
as well.
Well, and what else is really interesting here is though we're still describing it as necrotizing tissue changes. So interestingly, the conundrum is he still had dead tissue. So he's so critically ill, he's on vasopressors, there's not good perfusion, and there's dead tissue. So it's the retrospectometer is hard to say, should this have been debrided that aggressively or not? But your words throughout and the images were showing dead tissue. So whatever the pathologic process was that was causing it, even though it wasn't what we would be usually looking for, which is a necrotizing soft tissue infection, there was dead tissue. So the surgical right is still to cut away that which is dead and non-viable. So it's a really tough case you got here.
Yes, it was a difficult one. I think we'll, in the interest of time, we'll move on to our second case. Okay, we're gonna have to fast forward on some slides because this fellow is not here yet. I don't think. Jen, are you online?
Yeah, I just logged on. You just can't.
Oh, okay. Never mind. I'll go back.
Okay.
Sorry. Jen was in the operating room. Go ahead and introduce yourself, and then I will advance your slides for you.
Okay, perfect. Thank you so much. My name is Jennifer Meisheimer. I'm one of the second-year ACS fellows at Atrium Health. I will be presenting a relatively common case, but interested to see however everyone handles this. I think we've all had these patients that are kind of just recurrent offenders, thorns in our sides, whatever you want to call them. So eager to get started. So this is a 32-year-old male who presents with a 4-day history of abdominal pain. Very classic, migrating to the right lower quadrant. He has no prior surgical history. At the outside hospital, his vital signs were all stable, and his exam was significant for mild right lower quadrant tenderness to palpation without any rebound or guarding. His labs were relatively unremarkable. White count of only 12, H&H of 11 and 34, and his CMP was within normal limits. What imaging would you guys like?
I mean,
I'm sorry,
Do you
you
guys
said
get calls from the,
he-
do you guys
he's
get calls from the ED without imaging anymore?
he's
yeah, I was
ten-
about to say,
he-
like,
Yes.
that never happens.
he's he's tender in his
Called
right
us
lower
after we
quadrant.
have the SCAT scan, yeah.
Yes,
I
that's
guess the
correct.
question, I guess the question is, do we want any imaging?
Question. When's the last time you took someone to the operating room without imaging for appendicitis?
It's been 5 years since I've been given the choice.
Yeah, I don't, they always have it when it's done, and I mean when we get called, and at this point I don't really bark too much about it.
I'd say a CT scan. I think the sensitivity and specificity of an ultrasound in an adult is not high enough. It hovers in the low 60%, which is slightly better than a quarter. I would suggest if we're going to do an ultrasound, we just might as well flip a quarter and go with that. And if it comes back heads, we take them; tails, we don't.
Okay, perfect. Well, the ER did get a CT scan, as everyone presumed. I don't have Dr. Britzenhoff.
Did you guys lose my slide?
Yeah.
Yeah. You don't. 1 second. Let me try this again. There we go.
Okay. So here is the read. Visualize loops of small bowel are normal. There's a blind ending tubular structure, which is favored to represent the appendix. However, it's up to 3 centimeters in dimension, with wall thickening, enhancement, and some periappendiceal stranding. They're just reading it as a 3 centimeter acute appendicitis case without any fluid collection to suggest abscess. He was started on broad spectrum antibiotic therapy and given some IV fluids. Next. Here is a cross section of this 3 centimeter dilated appendix. Next slide. So what is your plan for this patient? In the absence of appendicolith, is anyone counseling patients on non-operative management and treatment alone with antibiotic therapy, or is everyone taking them to the operating room?
I do discuss non-operative management and the data behind it. I think in this patient, given the size, a little bit concerning. How old is he again?
He's young. He's only 32.
Okay. I think I would still opt for surgery, but would discuss both management strategies.
Agree with Gelbard. We are obligated to express the variety of choices in a patient-centered treatment approach, regardless of our own proclivities, albeit we can recommend and favor something, it's worthy of the discussion. In this particular instance, 3 centimeters, that nice juicy thing that we saw, is atypical and wide, and I would be worried about the potential for some other process besides just simple appendicitis, as well as the concern for some other pathology at play.
Yeah, I'm with Dr. Foster on this one, and I probably wouldn't even tell him about antibiotic only therapy, because I'm gonna go take that thing out.
Okay, so He was counseled on both, and the decision was made to take him to the operating room from the ER. I was not in the case, but from what I understand, the surgeon was unable to visualize the appendix intraoperatively. They encountered a very large phlegmon collection and abscess with purulent drainage. So what is the panel's algorithm for perforated appendicitis with a relatively hostile right lower quadrant?
Keep looking.
Yeah, same. Like, just because it's hard doesn't mean you can't do it, right? And so I don't bail super quick. If you can get through there and find it, take it out. If not, and you have your big abscess, and then you're putting your drain in right then. I don't routinely leave drains, but this is the similar component of an IR drain for a big abscess. You're just doing it in the OR, but I will try to spend some time trying to find that appendix.
I think the big difference in regards is what you're encountering intraoperatively. So if there's a phlegmonous mess of tissue that's unsafe to manipulate and stool continues to evolve, that is a conversion to a right hemi or a cecectomy in my mind. That's aggressive, get it out. You're not going to get it under control easily, as compared to I've evacuated it. The tissues look viable, even though I can't delineate the true base and have control, but with manipulations of the bowel, both antegrade and retrograde. So from the colon and from the small bowel, it doesn't extrude any further gross pus or gross fecal matter. Then it's safe to wash and drain. But I think that clear decision needs to be made based on the tissues encountered.
In my thinking, a 32-year-old, I would not leave the OR without a definitive solution to his problem, even if that meant I had to take out his right colon.
Move forward.
Sorry.
That's okay. My arrows are just kind of discussing. You can hit next what we all talked about.
Oh, yeah.
Nobody elected for open, and we did talk about ileocecectomy. So next slide. So they were unable to find or visualize the appendix, and it was very inflamed. The tissues were very friable. So they performed a washout and drainage. On post-op day 3, the patient was feeling well with return of bowel function, and they were discharged on oral antibiotics. He was seen 2 weeks later in our clinic and doing well. He was counseled on interval appendectomy and the risk of having recurrent bouts of appendicitis. Unfortunately, the patient refused. He re-presented to an ER 1 month later, so about 2 weeks after his clinic appointment, with new right-sided flank pain. They did get a CT scan before calling you, and it was read as acute, likely ruptured appendicitis, which has progressed from the first scan with a very complex collection extending this to the subcapsular liver, and his labs are below. Maybe we should go back a slide and ask what everyone would do.
Sorry. So recurrent appendicitis.
I think it's interesting. I would not have offered him an interval appendectomy the incidence of anything malignant in a person less than 40 is reportable. One could argue that even in less than 60, that's almost an albatross. Most of the reported data that talks about these 10 or 11% is almost entirely driven by the fact that people over the age of 60 that present with that. I don't know why I would think going back later, I would find any more of an appendix than I couldn't find at the time of his first operation. I mean, I think these patients already proven that he has an obliterated structure, and unlikely to find it 6 weeks, 3 months later.
Yeah, I mean, I agree. I think now you potentially have so the drain you left, I'm assuming there's a drain. I don't know when that was removed, but maybe not adequately controlling this infection abscess. So is, IR, percutaneous drainage, an option to just control that, temporize, see if you can get him, cooled off to the point where he could, get an interval appy at some point when it's safe. I don't know what the timing was when it was offered to him. But alternatively, non-op, well, just a washout, he's now recurred. At this point, he may need something more definitive, even if that means a colectomy or ileocecectomy.
Agreed.
He was taken to the OR. It was intended to be, the conversation had with him was appendectomy versus ileocecectomy versus right hemicolectomy. Due to inflammation, the surgeon performing the procedure did do a robotic ileocecectomy. He had a relatively uneventful hospital course. He did have a bit of an ileus for the first few days. Then on post-op day 4, he was advanced on his diet. His antibiotics were finished, and he was discharged on post-op day 5. But his story continues. Next slide. He represented just 1 day after discharge with blood in his stool. He was slightly tachycardic. His labs, again, were pretty unremarkable except for a drop in his H&H. He had diffuse abdominal, that should say tenderness, not tension, exhibiting signs of peritonitis. They did another scan. This is now post hemicolectomy, and he's got a new fluid collection. There's a small amount of fluid adjacent to the liver, and then there's fluid down by the anastomosis. With all of this information, is everyone going to return to the operating room or have IR drain?
And maybe comment on your use of robotics in EGS or acute care surgery at your institution, also in your practice.
The choice of laparoscopy, robotic, or open is surgeon dependent, and I see the spectrum at my various practice locations. Personally, I don't do the robot, so this was either getting done with the camera or open. And then the description of this patient's case, I probably would have opened it to have a more in my hands, a better look than I would have had laparoscopically, given the tissues that I would have expected only a month from the incident. With that said, in regards to the representation, to me, this is a leak until proven otherwise. And a leak, I'm not going to percutaneously drain. I'm going to investigate the good old fashioned way, like a gray-haired surgeon, which is get hands and eyes in there.
Yeah, I agree. I mean, he's not really septic or floridly septic, but it's also fairly early, right? He's post-op day 5 from his ileocecectomy. Some of this seems just non-specific fluid, but I'd want to know why, right? This is all developed, so I probably would go back in and look. You're still within a window where I think it's reasonable.
So he did go back for laparoscopic washout. They did not find any disruption in the anastomosis. It was mainly purulent fluid, but the anastomosis looked intact. He did have, during this third hospital stay, acute blood loss anemia with a drop in his hemoglobin. However, he responded appropriately. Again, he was discharged around post-op day 4 and was seen in clinic on post-op day 17 from this recent surgery and was doing well. Next slide. But his story still continues. Hospital course number 4. Next.
Like a worst oral board scenario ever. You think you're done?
I think we've all had patients that just, you think you're out of the woods and they keep coming back. So I think it's important to talk about out loud. So he represented.
I'll make a comment before you get. I don't know how this story ends, but I will say that a GI bleed in a young person with a suspected leak. I don't know, can't tell you the sensitivity of that, but it's always raises my antenna that that disrupted anastomosis is bleeding on the inside and leaking on the outside. So
yeah, I agree with Nate 100%. That's the first thing I thought was going to happen. You can't see, especially if you just look from the outside, you can't tell. Those things are bleeding on that staple line internally, but I'm with Nate. I started getting real worried when I have concomitant GI bleeding with a fresh anastomosis and then fluid around it, and then it's an interloop abscess these are problems.
So he represented on May 17th for similar abdominal pain in the right lower quadrant. Next. They rescanned him, and now he has a new large 13 by 6 centimeter abscess in the right lower quadrant extending up into the abdominal wall. And again, he has some prominent loops of small bowel representing partial obstruction. Next. His labs, again, are relatively unremarkable, has never really amounted a white count to any of these abscesses. Next. Now, what are we doing? This is nearly a month out from his robotic partial colectomy with a new abscess.
I think I would probably try to drain this percutaneously IR first. He's not really, again, systemically sick, has some pain, sure. You're at a 4-month point. Who knows how hostile that abdomen's still going to be. No leukocytosis. Like, I think you have time to try to drain this and manage it that way before attempting to go back. I would think if he had, a large anastomotic leak, that he would be far sicker.
I think we've got the benefit of this as a young, otherwise healthy patient who's been able to compensate and mount an appropriate localized inflammatory response throughout. But now we're in, as Rondi said, we're in the window of danger. So going back into this belly, no matter how young and forgiving he's been, now those tissues will be hostile. So we'd missed our opportunities to revise, resect, and do that right hemi or that limited colectomy early on, and now we're stuck with the percutaneous pathway and having to delineate if there's a fistula that will require other additives. And the other additive I'm referring to is if he continues to have problem without control, that percutaneous drainage becomes the put in another drain, remanipulate, determine a fistula tract, et cetera, then this young man still needs another surgery, but that would be a proximal diverting loop ileostomy.
Advance our time here a little bit. Next, he did undergo IR drainage. He was put on broad spectrum antibiotics. His cultures grew Clostridium species, and he was discharged home with augmentin in his drain. Next.
Was it pus or did it stool that came out of his drain?
From what I could tell, it was purulent material.
And then there's a question on there from the chat from Dr. Vella saying, any concern for IBD? I think as much as I would like to blame IBD for this, I think I have to try to blame Ethicon or Covidian, whichever one of those people made the stapler. And then as a last resort, I would blame myself as the surgeon. But maybe I'd try to blame the patient in between there somewhere. But I think, yes, I think that's on the differential if he kept coming back and we thought it wasn't leaking. But my presumption is this has just been kind of a leak from the get-go. For all the reasons we talked about at the beginning, because he just, poor tissue got stapled together because of the nature of his disease process.
Yeah, this, when it comes to complicated perforated appendicitis, unless there's just phlegmon where you can't see anything or a giant abscess, I try to go take it out at the first get-go. I do the operation, and if sometimes they need the ileocerectomy at that first time, then so be it. But a large majority of these, I think if you power through it, you get down, you get to the base, you can take the appendix. If you need to close that over, you can do that. And that obviates a lot of this other stuff down the road, because all these are subsequent complications thereof. And that's what I said earlier, like I don't even, when it comes to these sort of things, I don't even tell patients that antibiotics is an option. And some people disagree, that's okay. I tell them we're going to go take this out, because otherwise you're going to have a lot of problems down the road. And this is exactly what happened.
Just to clarify for myself, in this case, while I would have said to this patient that sometimes antimicrobials alone are viable, I would not recommend it here than what we saw. But additionally, I think if we have any, for our young colleagues and for people in training, there's this sense of, I don't know, it's almost attached to failure, or that we've done something wrong when we do perhaps something different or more aggressive than was the initial intent. And I think it's really important to use this as an opportunity to say, doing something quote unquote more aggressive, but to do the right surgery to fix the pathology and fix the problem is always more important. It's the same when we're talking about cholecystectomies and complex cholecystectomies, and the push now is to do things laparoscopic instead of open. So it's considered quote unquote a bailout to do only a partial cholecystectomy. If that's the right procedure for the patient with the tissues encountered, it's the right procedure. It's not a bad choice. It's not a failure. It's not too much or too little. It's addressing the tissues and the pathology the best way that we can. And so it seems overarching, and perhaps that's the way you presented this particular case, but there was always a measure of reluctance to do something that seemed like a bigger surgery that wasn't planned. So I think what Nate and Mike and Rondi and I are saying is doing the bigger thing early on would have saved 4 months of admissions and perhaps even ongoing disability for an otherwise young patient. This person's not working. This person's probably not being able to participate in athletic endeavors. Who knows? But this becomes a really significant problem for them.
Any other final comments? We have about 10 minutes in one short case. You want to get through it? Okay, we're going to move on to our third case. Thanks for your comments on that one, and I'll turn it over to Dr. Pinzo.
All right. Hello, everyone. Hi, Dr. Foster. I don't know if you remember me, but we took some call at St. Luke's together. You were on the knee scooter at the time.
Oh gosh. Yeah, that was a while back, but I ripped out my ankle and the residents were kind enough to push me around in a wheelchair and or a scooter for a few weeks. It was awesome.
So I'll jump into my case here. This is a 79-year-old male who presented with some acute onset epigastric pain. I have no financial disclosures yet. So this gentleman presented to one of our freestanding EDs, which I don't know if that was kind of a new phenomenon for me coming down to North Carolina from Pennsylvania. And he had epigastric pain since around 2:30 in the morning. His pain was constant, never felt anything like it before. He's a former smoker, some current alcohol use, no past surgical history. His vital signs a little on the hypertensive side, otherwise okay. On exam, he's a little bit tender in the epigastrium, a little bit distended, and no appreciable surgical scars. I put his labs here, really nothing jumping out. His CBC looks okay. The emergency department APP that's messaging you in the middle of the night asks if there are any other studies you'd like.
Yeah, it's 2:30 in the morning. This guy's got big abdominal pain, NOS. Again, this, they're going to need a CT scan if they want me to
Absolutely.
help diagnose anything, which is,
So because of the geography of the pain, they also send you the courtesy of sending you a lipase. They check the lactate that you requested and sent off that CT abdomen pelvis with IV contrast. These are some cross sections from the CT scan. What it's showing is that there's I'll kind of help you here because I don't have a video of it, but there's a loop of colon interposed between the stomach and the liver. The radiologist is reading the cecums around, I think, like 7-8 centimeters there, and concerning for a partial obstruction. There's the read. Anything concerning or maybe not explicitly mentioned by the radiologist about the geography of this colon?
it's not supposed to be there.
Absolutely. And so on our independent on our independent read,
in all seriousness, like how bad is his abdominal pain? And like what's eating habits and stuff been lately? I'm kind of, without being able to scroll up and down, I can't tell what's on the other side of that stomach, if that's compressed stomach there or if that's what's going on, but that's clearly AB normal.
Yeah. So he's hasn't been vomiting or anything. He's able to keep food down. He's not having like marked weight loss or anything like that. I'll tell you that the small bowel proximal to this, because this is his cecum, is relatively distended. But
and somewhere on that you could, that's just not a mobile hepatic flexure that's kind of sitting over there. Somewhere else there's a hepatic flexure that's independent of that cecum. Like, it's obvious on the imaging that that's his cecum, not as just mobile transverse and right colon
right.
over
This is very much his cecum, and there's I have some pictures later that'll kind of help elucidate what else is kind of stuck up in that area.
And his previous surgical history was what?
Zip, zero, zilch.
Has he ever had a colonoscopy?
Good question. I'm gonna say no.
And was there any comment on the CT scan about, like, even though it doesn't really look in these images like volvulus, anything like that?
Yeah, no swirling or anything like that. Just kind of calling this like early obstruction. And just in the interest of time, on our read, we commented with the provider that this looked a little bit more like a foramen of Winslow hernia, after having the ability to kind of scroll through the imaging. And so, with the kind of limited information that you have, how would you counsel this patient?
With the way that CT scan looks, his symptoms, and the fact that he's never had prior surgery, I think something's going on and he needs an operation.
Yeah, and I'd start this to the previous question, minimally invasive.
Mm-hmm.
I don't have anybody. We're just now getting our robotic platform for the tax team. We only have one surgeon who's going through the process, but the plan is to get more people to do it. But I think this is virgin abdomen, colon herniated through an empty space in the abdomen. I would try to start this laparoscopically and try to gingerly reduce that colon back out to where it's supposed to come.
Yeah, and so we largely felt the same way. So this patient was transferred from that freestanding ED to our hospital, had an NG2 placed for decompression. His exam was stable overnight, and he went to the OR first thing in the morning. Would you bowel prep this patient? We kind of talked about operative approach.
Nope.
No.
I wouldn't.
Minimally invasive. Yep.
Yeah, any concern that there's a closed section of the colon, don't wanna fill it up anymore.
Yeah, exactly.
Right. Excellent. So we started we consented the patient for a diagnostic laparoscopy, possible reduction of hernia, possible cecopexy, possible right hemikolectomy. And so
was this thought to be an incarcerated internal hernia through the foramen of Winslow? Is there a hernia?
Large bowel obstruction through the foramen of Winslow. Yep.
I would just ask. It's interesting. Was the headlights on the surgeon's car broken, or was there a tornado coming through the city of Charlotte at the time, or something, or was unsafe to be on the roads that we couldn't? Typically, like you say the words large bowel obstruction and an incarcerated internal hernia, many would suggest that that's not a decompressive and watch case. That's a go to the OR middle of the night kind of case.
So he had pain since 2:30 in the morning, and so I think the time between getting him from the freestanding ED to the hospital is being first case in the morning, the way it plays out in real time is a little shorter than I may have made it seem. And so in the OR, the stomach appeared to be compressed posteriorly, and you can kind of see some bowel kind of pulling up in that right upper quadrant. We opened or got into the lesser sac, and you can see that colon bulging in the picture of on the right there. And it was difficult to reduce. So what we did was we placed a purse string and needle decompressed that incarcerated colon, now reducible. There was a big cecal bascule that was densely adhered to the right upper quadrant and gallbladder. At this point, with what you found intraoperatively, what are you thinking in terms of your definitive management here?
Can you clarify, like, reduce? I guess in my mind, Freeman and Winslow, and never seen one, would be you're trying to pull it laterally out from behind the hepatic flexure, like he's had a big poker procedure. Or when you tried to reduce it, which way were you pulling it?
Yeah, so trying to pull it laterally. And I think it's kind of a culmination of two things: the marked distension of the colon and the adhesions that weren't readily appreciable until you kind of decompress the colon to the right upper quadrant and gallbladder.
Yeah. Anyway, I guess that makes sense. I would take that out. To answer your second question, there's zero chance I would do a cecopexy and that thing.
Yeah.
Yeah, I'm also wondering, in terms of the procedure of choice, the idea of a needle decompression. So we made a cecotomy to evacuate the air because it was not reducible.
That. So that was my impression from the operative note.
Fair enough. That makes me nervous, but that if there was no other way to get it down, then so be it. But in regards to the adhesive process identified that caused the bascule, was a complete adhesiolysis performed such that the tissues then laid in an appropriate anatomical position, or was the colon still upward?
It eventually, after that was decompressed, yes, all that was lysed, which kind of segues into the next question. We had planned for a right hemicolectomy based on that, and so I think that also kind of contributes to feeling okay about decompressing the colon if you know you're going to take it out anyway. And so you mobilize the colon to get ready for your resection, and the gallbladder looks absolutely horrific, congested, inflamed. Is anyone going to leave it behind, take it out?
So we're finding that the pathology is cholecystitis that led to the inflammatory and positional changes of the colon.
That's kind of what your impression is in the operating room.
It's chicken and egg thing here.
Yeah.
Like, did the cecum fold up on itself and then get it, inflamed and hit the gallbladder and pop out through there, or is it the other way around? And
would anyone want to come back again after handling this right upper quadrant to
no,
take the gallbladder?
I'm gonna make my decision and then it's gonna be done. I'm not gonna come back looking around. So if I think that the gallbladder is a problem and it really does look, and getting it adhesed, colon off of it, I'm worried there that I really thinned it out and did something to it. And if I'm there and I'm probably just gonna take it out and be done.
It is interesting that he had completely normal LFTs, including a normal alk-phos and a normal white cast bill on his.
Yeah, I'm kind of worried there was a compression from the colon up through the foramen, causing like a pseudo obstruction cholecystitis. Now that that's done, it might get better, but I still take the colon
I
out.
would take it out too, I think.
Yeah.
To avoid having to go back in there. I mean,
yeah, because the worst is like a week later, like, hey, you still got right upper quadrant pain, and now re-imaging his gallbladder is all inflamed, like that.
Yeah, sadness. Would anyone do anything else before leaving the operating room?
I guess I would try to maybe close down that
Yeah.
space, either with
Yeah.
some sutures or a piece of momentum or something that made me feel like I was keeping the next piece of small bowel from migrating through that hole. But
Yeah, I don't
with
know
the
what it's
given-
what to what.
yeah, with a given sense that I probably wasn't really doing any type of repair, but just making myself feel better.
I'll put a stitch in there before I left.
Exactly, and we had the same thought, so we tacked some momentum up there. So post-operatively, having bowel rest, waiting for return bowel function, got the Foley out. Post-op day 2, they removed the NG tube after a clamp trial, got transfused unit blood. Any thoughts on clamp trials?
Yes,
No?
please, dear God. I feel like the residents must have called from Wake Forest to tell you to put that on there. Like, just be a doctor. Quit being chicken. Like that. It's a binary decision. Unless you like your patients to aspirate and have pneumonia, quit being a chicken and just decide either it needs to come out or it needs to stay in. But like, the only thing NG tubes have ever been shown to cause is pneumonia. They never have shown anything else. So you could argue you never should have had an NG tube to begin with.
I love
If you
that.
want to stent open the 2 sphincters that the good Lord gave you to keep you from aspirating, then by all means clamp the NG tube and aspirate. Otherwise, take it out.
I literally had this argument with 2 different services today in ICU, and I was like, no clamping.
I kind of include that bullet because I feel the exact same way.
I mean, especially
so-
right in an older adult, right, who may have some delirium, right? They're not going to protect their airway, you know, and they
Absolutely.
So
It's either in and working or out.
correct.
All right. So this guy's diet got advanced, and he ultimately got discharged home on post-op day 5. Just I had included this just as a point of discussion, but patient with no previous abdominal surgery. Any thoughts on approaching or differences in approach with someone presenting as a SBO versus an LBO in a virgin abdomen?
I think as Mike said at the beginning, I would do the same, approach it laparoscopically and see what can be accomplished. Because then if you did it, great. But with a low threshold to convert to open to really get your hands in there. And the image that you showed, as well as what was described, is that the cecum was so markedly distended that it wasn't safely manipulable. Well, I'm much more likely to be safe to manipulate something with my digits than I am with the hard laparoscopic instruments. So when you see that, to me, that's the indication to convert.
Yeah, I think there's a rampant misconception that people who've never had an operation can't have bowel obstructions. And so I put that as a huge caveat to everybody, that they can have both small bowel obstructions, they can have large bowel obstructions, internal hernias. If some people have had appendicitis that they never treated, never saw a doctor for, and it went away, and they've got a disease, cholecystitis, pancreatitis. There's all sorts of stuff that people can have that can cause a bowel obstruction when they've never had an operation. So don't discount that.
Yeah, and women can be prone to it from adhesive disease, from any gynecologic disorder. So there's lots.
Lots and lots of reasons out there. So don't discount it. And as Dr. Foster said, it's even easier to go on with the scope.
Has anyone found anything particularly bizarre on exploration in a virgin abdomen?
A foreign object.
Or not just, I mean, malignancy, right? For especially large bowel obstruction, you definitely have to think about that, especially, older patients, but I would definitely work up for that as well.
Yeah. All right. And so just briefly, foramen and Winslow hernias, rare type of internal hernia. We kind of touched on it a little bit, but it sounds like the literature is largely mixed in terms of closing the defect. We kind of talked about approach, just whatever you feel like makes you feel better at the end of the day. And then that's all I have.
We are out of time. So I'm going to wrap up this session. Thank you everyone for joining. Thank you so much to our expert panelists for all of your expertise and knowledge. And thanks to our fellows for presenting. And y'all have a good night.